So the purpose of my being here is to talk about privacy and Obamacare. So let me just make it really clear, there is no privacy in Obamacare. And I'm just going to show you how that's true. So the ACA violates patient and citizen privacy, but it really uses a lot of laws that were set in place before Obamacare got passed. And so it is just using these laws to advance and strengthen the privacy violations that were started in advance of the passage of Obamacare. And those include Hipaa and high-tech, and I'll say more about them each specifically in just a moment. But to be clear, the elimination of privacy began with the enactment of Medicare, because he who holds the gold makes the rules. So he who holds the data makes the rules, but he who holds the gold also makes the rules. And it was inevitable that the rules would soon require data to be sent to the federal government. And as Vermont Governor Shumlin, or however his name is pronounced, he said, technology allows the government to do what they couldn't do before. And he talked about how it could combine your income and your insurance. So this is a lot of information that the government has on you to make that kind of a decision, including financial information, insurance information. And thus having access to patient and citizen data gives the government control that they never had before. So first, just a little history. And I know this is a very well-educated group, but I also know there might be things that you don't know. So just as a foundation to where we are, it's good for you to know a little history about Hipaa. So Hipaa passed in 1996, and it included a section called Administrative Simplification. And yes, and that is a bit of a euphemism. But it required ID numbers, ID tracking numbers, for patients, doctors, insurers, hospitals, clinics, and employers. Now, thankfully, Congressman Ron Paul has regularly kept the patient identifier, the patient ID tracking number, from being implemented by HHS. But we just put out a paper last year, I believe, that talked about the continued advance of the national patient ID system. And so if you would like to take a look at that, you can see how the things they're doing, trying to get to a point where they have each of us with a national ID and medical tracking number. They're not there yet, but they're still trying. Also in administrative simplification was the computerization of all electronic medical records. And without Hipaa, that couldn't have happened. And it also required a privacy law to be passed, or HHS rules if Congress didn't pass such a law. But of course, Congress couldn't pass such a law. They could never get themselves together to do such a thing. And so they put it on HHS to do the dirty work. So HHS came out with a rule in December of 1999, and then that rule was proposed. There were more than 50,000 comments on it, most of them all asking for consent. They added some consent, and then when Bush came in, he took away that consent. And then in August of 2003, the rule became effective. So what the rule does is it allows access to private medical records by 600,000 entities. And it requires doctors to hand over a notice of privacy practices to their patients. And most patients are actually convinced by the notice of privacy practices, that lovely little word there on the top called privacy, and they don't actually read it. In fact, one Minnesota legislator, I said, what does that mean when you sign that paper? He says, that means that my information is between me and my doctor. And that's what the public really thinks. And so you'll hear some things today that we're doing to try and get the public to know a little bit more about what Hipaa is and how they don't have to sign that paper. So in essence, Hipaa is not a privacy law. It is a no privacy law. It is a disclosure law. It has nothing to do with privacy except eliminating it. Well, then came high-tech. And high-tech is the Health Information Technology for Economic and Clinical Health Act. And that was part of the Recovery Act, or the stimulus bill of 2009. And it gave numbers differ, $27 to $34 billion for health information technology to build a national medical record system, or a national health information network, or as now it's called a e-health exchange. It required interoperable electronic medical records by January of 2015, or there would be cuts in reimbursement to doctors who didn't choose to comply with this voluntary so-called mandate, or so-called voluntary mandate. And it also required meaningful use of the medical record. So you couldn't just get an electronic medical record, and it couldn't just be interoperable. You actually had to make it interoperable, and you had to use it for what the government says, which includes sending data to the government about your patients and your practice. And so you get money to put the thing in, and then you get to pay the cost forever after. And in the process, you violate your patient's privacy by handing over this information to the government. The law, high-tech, also added 1.5 million business associates. So a rule in August of 2010 by HHS lists out the number of people who have access to medical records without consent, and it is more than 2.2 million entities. So there's a lot of people in those entities. So you can see that this has nothing to do with privacy. And so besides everything mentioned already in this great conference about electronic medical records, I want to mention a few more things. The FDA has said that there have been at least 6 deaths and more than 40 injuries due to the electronic medical record. One study showed 22 new medical errors due to CPOE, computerized physician order entry. Another study showed increased mortality in a pediatric unit. And then, of course, there's just the fact that the whole thing can shut down, as it has, leaving nurses and doctors without anything about the patient at all. And then last, of course, is that it just gives control over the practice of medicine. One doctor told me, if it's not on the computer screen, I can't do it. Right? So this is not what the patient understands. And then now, of course, comes the ICD-10. So this will be the tracking of patients in an unprecedented fashion at a level that has not currently been possible to date. But if you have an injury, they will know what room in the house you had the injury in, because that's part of the code. So if it's in the bathroom, it's a bathroom injury. If it's in the bedroom, it's a bedroom injury. There are 9 possible codes for injury from a macaw. And they'll know whether it's the first time or the second time you hit the lamppost. So, you know, it's very, very detailed. But specific to Obamacare, above and beyond everything else that I've talked about and is currently happening, we have a brochure outside that some of you have probably all already picked up. It's called Privacy and Healthcare Reform, 10 Things Patients and Doctors Should Know. And so you can get some details in here, and actually we would love it if you would like to have this in your doctor's office and let people actually know what's going on. So in Obamacare is dependent on data to actually impose national health care. And the master control of Obamacare is the Health Insurance Exchange, or the American Health Benefit Exchange, as it's actually called in the law. And I'll explain that a little bit more in a bit. But in the law are things like prevention and wellness tracking programs. So they're giving grants to employers to get their employees to fill out questionnaires and get physical exams. And then the employers have to report back to the federal government how the employees are doing. There's the annual Medicare employee enrollee inspection. Now they call it an annual wellness visit, but I call it an annual inspection. And there's a special tracking of people between 55 and 65. There are the home visiting programs to send government workers into the homes of people and write information about their relationships, the safety of their home, their environment, their conversations, their health care, everything else that they can gather. There's something called elder justice, which is taking information from the nursing homes and other kind of long-term care facilities, clinical information. And of course, there's the criminal checks now of physicians. And then there's the part about Obamacare, which allows, it's just a small, tiny section of the law, but it allows HHS to prohibit any health insurance company from signing a contract with a doctor who is not providing quality health care. So just let that sink in, because HHS gets to determine what quality healthcare is, how will they do that? Through your electronic medical records. And then they just put you on a blacklist. And then there are no contracts with insurers. Now, of course, I'd prefer you not to sign any contracts with insurers or Medicare or anybody else. But the fact of the matter is that shows the power of HHS over the physician. There's a bill by Congressman Phil Gingrey, called the SCOPE Act, Safeguarding Care of Patients Everywhere, to repeal this tiny little but very powerful section of Obamacare. Then there's IPAB and PCORI. PCORI is the Patient-Centered Outcomes Research Institute, which is using millions and millions and millions of dollars to do what I call rationing-based research. So they will be doing cost-effectiveness research, all to figure out what's cost-effective and what isn't. And as Adam said today, 20% of the people are never going to fit into anything, right? And those 20% of the people are the ones that are going to be hurt the most in the standardization of medical practice that will happen through PCORI. And then, of course, in the rationing, the more direct rationing through IPAD, the Independent Payment Advisory Board, which is going to tell doctors whether they will get paid or whether they won't get paid, or who they will get paid for, and at what age they might get paid for such and such a patient. At such and such a patient at such and such an age. So it's all about using data to build rationing protocols. So now on to the exchange, which I consider the master control of Obamacare and the mother of all surveillance systems. So we have a variety of names for this exchange. Now they, of course, call it the marketplace. And you, of course, know it's nothing such. It is actually a bureaucracy. The marketplace has long existed, has always existed since people decided they could give one thing to get another thing. There's been a marketplace. So the federal government cannot create a marketplace. So it's a federal takeover center. It's an Obamacare implementation center. It's an IRS enforcement center, a national insurance status tracking center, and a wealth redistribution center. So those are our 5 names for the health insurance exchange. And we have a diagram out on the table, which Fox News has used and others to try and explain to people what the exchange is. And you can pick it up on the table on your way out. But what I like to say the exchange is a vast national IT infrastructure for sharing and tracking of data and the transmission and transfer of dollars. So there's only one exchange, and it's a national exchange, and it's made up of a central server, IT lines, and 51 dummy terminals, one to every state and Washington, D.C. Now, it hasn't quite worked out that way because only 16 states and Washington, D.C. have actually decided to build this thing. And what it really means is that the state is the one that's going to fund the IT connections and the infrastructure of their website. They're going to fund their dummy terminal. And then they get to call it a state exchange. But it's just a terminal of the national exchange. And Obama was hoping that all the states would fund their little piece of the national product, but only 17 states in D.C., 16 states in D.C. have. So essentially, the exchange is a website portal. So it's a place you go online. In Minnesota, it's called MNsure.org. And in California, it's called Covered California. And in Connecticut, it's called Health Access CT. And in Kentucky, it's called Connect, K-Y-N-E-C-T, Connect. And so that's the first part of it. Then there's the IT infrastructure, all the connections that hook it to the hub, the central server, the Federal Data Services Hub. The Federal Data Services Hub is more like a record locator service. So it is an entity that once the person sits at the website, puts in all their data on this federal application form, and they press send, and when they press send, it pings the hub. And then after it pings the hub goes into the state agencies through all these IT lines and gathers information on this person to verify that this person is who they say they are, to find out what their employee information is. And then it pings the federal government, at least 5 agencies of the federal government, to find out their citizenship status, to find out their social security number, to find out their incarceration status, their tax status. Everything that is being collected here, it's also going to be collected on their family family status, their household income, not just their income, but their household income, then all of this stuff goes to a central database. Now, the central database is not the hub. The hub is a data collecting tool, but in February of this year, CMS came out and said, we are creating a new federal system of records called the Health Insurance Exchange Program. And you have 30 days to make a public comment about this thing. And when I called later, not one person had made a public comment, which I think means that the entire public has no idea that it's out there. Maybe even agencies don't know that it's out there. There was nothing. So this is a new central database, and what it will do is keep all the data on the individuals who give it to the hub and all the data that the hub collects, and it will all go into this new central database. So all this information on your tax status, your citizenship, your family, your employer, your income, wages, everything is going to be in this new central database created by the federal government. And, but it's not going to just be on you, it's going to be on your employers and the employees, and it's going to be on insurers and brokers and navigators and contractors, and anybody having anything to do with this national exchange system will be in this new database. So right now, when it comes to health data, it's limited. There are only 3 things that the individual is asked for, and they continually say there's no health data. There's no health data in the hub. Well, there are 3 things that the individual is asked for: whether they smoke, whether they're pregnant, and whether they have a disability. So those are 3 things for sure that are going in. But then I think there's going to be a whole lot of sharing later. So the URL, this whole, when you go to MNsure or you go to Covered California on the website and you're looking at the page, right? This page setup and the way this whole setup works was created by 3 federal agencies, CMS, HHS, and UNC, the Office for the National Coordinator of Health Information Technology. And UNC is the one that is creating the National Medical Records Database. So I think that the 3 of them are together in that because they plan to share the data. And in fact, one thing that people are supposed to get when they go onto that website is they're supposed to find out who's the most high-quality, low-cost doctors. And so information from the patient medical records and from your compliance, your quality metrics, is going to be reported in the exchange. And so, and then the other thing is that I'm going to be speaking at a conference in a month in Washington, D.C. on health information exchange. And one of the conference titles is Connecting Health Data to the Health Insurance Exchange. So I think that a person's health records and the person's insurance status and the fact that the IRS has all this access to all this data is probably all going to be combined in this database. Well, the interesting thing I think about the quality data on the exchange is that the data is compliance data. So how your willingness to comply with their practice treatment guidelines and other things is how you're going to be scored. And in fact, the worst doctors may look the best because they're just the best compliers. And then there are narrow networks in the exchanges which are going to limit access to doctors and hospitals, which is one of the ways that they're going to keep the cost of the plans lower, is by limiting the networks. So all these people coming in thinking that they're covered, having very limited access to doctors, and the only doctors they're going to hear their quality score on is this limited network. Now, the exchange might be delayed. This is sort of the latest thing that we're hearing. There are various tremors of this in the news, but here's something for you to know about the security of the data. The data security is suspect. As a matter of fact, the Inspector General of HHS said that there was no way, essentially, that HHS could even do the security testing until September 30th, the day before the exchanges were supposed to be operational. And the House decided to hold a hearing on the data security of the exchanges. And voila, 5 days before that hearing and 3 weeks before September 30th, suddenly HHS came out and said, we passed our data security. We're all set to go. And the Inspector General had to sit there in front of the committee and say that no, they actually had never seen any documents that would verify this, and they'd never tested it, and they don't actually plan to test it or verify that the data is secure. It has been self-attested to by CMS. What we do know is that the navigators have no background checks, so anybody coming out of jail could just decide to be a navigator, take all this Social Security information, number information, and other data, and use it as they wished. This whole system will be hacker accessible. After all, the Pentagon is hacker accessible, so we know this will be, and fraud friendly. And MNsure, as just an example of what can happen, MNsure, the Minnesota Exchange, recently sent out Social Security numbers and all sorts of other data on all 2,400 insurance agents. They sent it to one broker. And now we've had 2 hearings already in Minnesota about data security of the exchange. So as I conclude here, I just want you to remember 2 things. I want you to remember that he who holds the data makes the rules. This is really powerful. He who holds the data makes the rules. The exchange will be used to police the mandate and impose compliance. 700 pages of ObamaCare are a rewrite of the IRS code to empower them to police Obamacare. And then the second thing is that the exchange, and this is good news, the exchange is the Achilles heel of Obamacare. They know it. The thing that they are most afraid about is that they will not get people into it. Because as I said, this is the Obamacare Implementation Center. If they do not have all this data on us, they cannot impose the mandate. They cannot expand Medicaid. They cannot bring you into the new Medicaid for the middle class, which is what exchange coverage is. Obamacare coverage is just Medicaid for the middle class on a sliding fee scale. So we have a Refuse to Enroll campaign, and we have a flyer for you, and you could get a 4-color flyer on our website if you want to. You can just go to refusetoenroll.com, and I'm sorry, refusetoenroll.org. And so we have this national campaign. We have a flyer with 4 reasons to say no to the exchange. We have a 15 reasons 2-pager to refuse the exchange. We have had a billboard and some bus shelter posters, and there is a declaration coming for people to declare that they are refusing to enroll in the exchange. And what you can do personally with all of this in mind is to refuse the electronic health record, or if you like the electronic health record, just refuse to connect it anywhere outside the clinic. You should sell privacy. You should sell privacy as a benefit of your practice. It should be on your billboards. It should be outside your office. It should be hanging wherever. Because privacy on both sides of the political fence, everybody likes privacy. If we get any wins when the Democrats are in control, we get them on privacy. So sell privacy, market privacy. It's a huge benefit. And those who have to share their data, your data with 2.2 million entities, can't sell privacy. You should provide your patients with our Hipaa privacy brochure. I'd like you to. And our Refuse to Enroll flyer. I'd love you to go cash. New Hipaa rules allow patients to limit data. And of course, if you're cash, they won't get that data at all. Don't give government access. And then use some of our resources, the Refuse to Sign Hipaa. So we have a Refuse to Sign Hipaa. And all of you probably have a Hipaa form in your office. The HHS actually says your patients don't have to sign it. We don't want them to sign it. We have a new little card. You can have a whole bunch of them for your office. People are getting them from our office. And we're just sending envelopes of these cards everywhere. Because I've had patients come to me and say, I refuse to sign Hipaa, and they wouldn't give me care. And one person went in for a C-section, and she refused to sign, and they sent her home. So let people know they do not have to sign Hipaa. And if you go to Hipaa Notice, bit.ly/Hipaa Notice, then you can find, that's right on this card, you can actually see the page where HHS says you don't have to sign Hipaa. We have the 9 exemptions to Obamacare. Everyone should see if they can become one of them, including through health sharing. We have Medicare needs an escape plan, not a rescue plan. I don't want a Medicare card in my life. I do never want a Medicare card. So our whole plan is to get out of Medicare. We have a 5C solution, which adds to Lee's to say confidentiality, number 4, and compassionate care, number 5. Compassionate care means the regulators get out between the patient and the doctor. So here's the bottom line for our organization. We believe that Obamacare will be repealed. And the way I say, the reason I say that is, yes, it may fail, but we want to repeal it before it fails. The reason I say that is because if we have Obamacare in our nation, we are America in name only. So I don't believe any of you, and certainly not our organization, is going to stop until we have this thing gone. So we say resist, repeal, reclaim. We are in the resistance phase. We've given you tools: refuse to enroll, don't sign the Hipaa form, cell privacy, etc., to help you with the resistance part. Do everything you can. We believe that we can reclaim health freedom, and I want to just thank you for what you're doing today, what you're going to do tomorrow, and ever after that to help in the resistance towards repeal campaign. Thank you.